Okay, sure. Can everyone hear me? Okay, great. So I'll start with some of these questions that were submitted about the fatigue talk that I gave. So here's a question: why is cooling therapy thought to help manage fatigue? I would say the main kind of explanation that we have is kind of going back to that idea that there's a problem with conduction efficiency of the nerves, and that we know that heat can worsen that a little bit. And so really the idea is that if you can cool the body down, maybe that helps the connections be a little bit more efficient. But I don't think we know a ton about that, but that's kind of our best understanding. And then the other question on this card is birth control thought to play a role in hormonal causes of MS in women? And I think it's going to depend a little bit on the person. I will just say there's no contraindication to using birth control in people with MS. And kind of thinking of it more on like hormone replacement therapy for people that are going through menopause, that's definitely something that's okay with MS and actually might be helpful because menopause or hormonal symptoms can kind of go along with some of the MS symptoms that we see, like fatigue and cognitive issues and sleep. So I think it's important that those things are being addressed and there's no problems from MS itself. Of course, it would depend on your other medical history and everything, but no problems from an MS standpoint.
Okay. Yeah, so I'll answer a couple of questions that I'm going to group together that came in on the note cards. There's a couple about the MRI volumetric tracking and things like that. So one question was just if you're a patient at our center, are you automatically getting the AI tools on your MRIs? The answer to that is not necessarily. It depends on where you physically are getting your MRI. But if you have not talked to your doctor about that, I would just shoot them a message and ask because we do have the information and you could access it. And then this question was very similar. As far as when I mentioned noisy, so I was a little bit, probably said something confusing. When I mean that the ICO brain thing is noisy, it has a lot of like false positive results. There's nothing changing from like the technical experience of getting the MRI itself. And we don't do a lot of MRIs for monitoring with contrast dye, but AI probably will not be changing that plan. I think there was one other one in here about that. Okay. And I'll answer one other one and then we can switch back to Dr. Upchurch. So this question said, can AI basically lead to a decline in skills for doctors and have people use like unvalidated results because you can just type things in and not think about it? I would say absolutely that is a huge concern. So for those of you who have followed the more general literature on AI, especially with like undergraduate and high school education, there's enormous concerns about people just like using generative AI to make all of their work as opposed to actually doing it. So I think that is a huge issue. I never use AI like upfront to do things. It is super valuable for us as like a sort of check the answer, make sure we're not missing something. But like I said, you have to have the ability to interpret like when it's wrong, and it does not do, I think, as good of a job, as we do, of course. So, but huge concern.
Okay, great. I will go through some of these other questions. Sorry, I should have lumped some of these in with the other question before. There's a specific question about my opinion on the benefits of cold plunge therapy for MS. I'm not aware of that being studied specifically, but again, I think with talking about cooling therapy, I think that it could be beneficial for some people, and I don't think that it's going to harm anything MS-wise. So I don't have a specific opinion on how long or the frequency of doing this. I know this is something that's become more popular just in general for people with managing like mood and like fatigue in general. So I think that again, there's no harm in trying that. This next question is, might there be a way to get insurance coverage on wearable technology like the smartwatches and rings? I don't know if Dr. Wolf knows this. I'm not aware of that. I don't know if it depends if certain types of insurance may cover some of that, but I've never heard of a patient getting their smartwatch covered by insurance, although I wish that that was possible. I don't know.
Yeah, unfortunately, not typically. There are sometimes some like employer-sponsored plans to like promote physical fitness where like fitness trackers can be purchased, but not usually directly like from insurance coverage.
This next question says, in someone diagnosed with MS, if most sleep apnea events are central sleep apnea events, are they likely attributable to the MS? That's kind of an interesting question. I I think, most like when I was sharing the statistics about sleep apnea, I'm talking about obstructive sleep apnea being more common. And so I personally don't know the rates of central sleep apnea in MS, but I could theoretically imagine that if you're affecting like certain areas of the brain, that could be possible. And then a couple more questions. Are folks with MS more likely to develop foodborne illness? Not that I'm aware of. I don't know, Dr. Wolf.
Yeah, not typically. There, of course, if you're immunosuppressed, there's a little bit more risk of getting sick from things, but there's not a signal for that specifically that would be different than any other sort of infection.
Great. And then there's a question on prism lenses and glasses. I actually just met a patient yesterday who has gotten tinted prism glasses, and that's really helped him specifically with dizziness. But again, I think it's going to depend on your specific situation. And again, it's not something that would hurt. So if you find that helpful, I think it's okay to try.
Okay. Then I'll answer another one. So, should people with MS avoid taking statins, which are cholesterol medications? Can those contribute to demyelination just because cholesterol can be a component of myelin? So this is actually interesting. So this has been a concern at different points. And there's also been thoughts that statins have other benefits, including on inflammation and like remodeling. And we know also that vascular risk factors, high cholesterol, hypertension, et cetera, can also cause additional damage to the brain and basically add to injury from MS. So there was a very large clinical trial completed in the UK about a year ago that was actually trying to use a statin as a treatment for MS, specifically for progressive MS. That study unfortunately did not work, or we did not see a benefit for adding the statin, but the statins are perfectly safe to use and are likely helpful in a large way for people that otherwise need them from having high cholesterol. So I would not have any concerns about using statins at all if it's otherwise indicated. And we can pick some of these drugs out, or some of these questions about drugs out from this list. So I'll try to group a couple of them together, just about new medications. One question is about Ocrevus. So there's been a new formulation of Ocrevus called Ocrevus Zunovo. Ocrevus has been out for about 8 years now. It's traditionally given as an IV. There's a newer version that is given as a subcutaneous, so under the skin infusion, just into the abdomen, and it's much faster. So that infusion can be given in about 10 minutes, as opposed to up to several hours for those of you that are used to the IV version. The data suggests that the drug has the same efficacy and same safety as the intravenous version. So if that sounds more convenient to you, I would really not have any hesitations about switching. And I would say for a lot of my patients that are starting Ocrevus, they often are choosing this just because it tends to be more convenient just based on the infusion time. There's a couple other ones just about new medications. So let's see. Actually, I'll answer one other question about Ocrevus first. So there's a question about how much more likely are patients using treatments like Ocrevus to develop cancers. And so the answer is that this is probably not a significant risk. So there was some suggestion from some data from the Ocrevus initial studies that there was a signal for increased cases of breast cancer in the group that was on the treatment. From a mechanistic standpoint, based on how Ocrevus works by killing B cells, we have not seen a risk really for cancers with other drugs that do this, nor have we seen breast cancer as a risk with patients who do not have normal B cells at baseline from genetic conditions. And we've now had, I think, 400,000 or so patients like globally that have been on Ocrevus since it was FDA approved and in the clinical trials. And the follow-up data has also not suggested that there's a risk of cancers that is elevated. So I personally don't really get concerned about this outside of typically out of a total abundance of caution. If someone has had a history of breast cancer or is ultra high risk, I tend to avoid using Ocrevus. But overall, this is not really something that I get concerned about. I don't know if you want to answer one.
Yes. Sorry, there's so many good questions to choose through. I think like one of these that I wanted to address was like how immunocompromised are people on B cell therapy? Specifically, this question is how immunocompromised am I on Kesimpta? And so I would say like these medications are different than like a full chemo where you kind of have to be like in a bubble or things like that people might think of. And I think of generally with the B cell therapies being at higher risk for viral infections more so. And so I always recommend that people be careful specifically with things like respiratory infections and colds and avoiding people who are sick. I recommend staying up to date on like flu and COVID shots and doing basically like, you know, these preventative measures that you can to keep yourself from getting sick because there is an increased risk, although I think compared to other immunosuppressive medications, it's not quite as much. And I don't know if Dr. Wolf, you have anything else to add to that one, but I think I get that question a lot in clinic, so.
Yeah, there's a couple other infection questions. There's a question about after taking a B cell depletion therapy like Ocrevus, will you have problems with immunity to older vaccines, so like MMR or polio? The answer to that is no. We don't expect you to lose based on the way the drug works, your older immune system. It's not always entirely clear to us from the parts of the immune system that are reduced by Ocrevus, like how long it takes to recover after stopping the drug. Like sometimes it can take a few years for the immune system to recover totally to normal. And then I wanted to ask a couple just about extended use of medications. Or I guess one about starting. So what is the effectiveness of Kesimpta? It's very effective. How long does it take to start working? Typically, we would expect it to hit peak effect similar to drugs like Ocrevus and Briumvi, where we would say 8 to 12 weeks, although it starts working very quickly. We don't sort of like get worried if it's not working until we get to about that 3-month mark. There's a question that says, if I'm taking Tysabri for 13 years and no relapses, do I continue or change to another medication? The answer to that is it depends a lot on personal circumstances. But for my patients that are on Tysabri, if you are tolerating the medication and you don't have concerns for wanting to get pregnant, or have your JC virus antibody, which should be checked every 6 months, change. There's really not a great reason to go off of it. There's a second question about chance of rebound. So if you're on Tysabri and you stop the Tysabri, there is a risk that the MS can flare up basically as the drug washes out of your system. So at least for my patients, I pretty much always will quickly transition them to another medication. And then last one about drug timing. Is it okay to be on Ocrevus for an extended period, 7+ years? The answer to that is generally like, of course, but there's some individual factors about how active is the disease. Are you having side effects from the medication, infections, things like that? But there's really not a significant concern if you're tolerating it for being on the drug for a long time. There are many patients in our clinic just with Ocrevus being out for about 8 years that have been on it for that long. And then quite a few patients that have been on a similar drug, rituximab, dating back probably 15 years or so. So, okay. I think I'll answer one more just on this section. So there's some questions about myelin repair. So I think for those of you that have heard me talk about treatment strategies in MS, like we have a ton of drugs, every drug really that's approved for reducing the risk of relapses. We have fewer drugs that are effective for treating progression. And we don't have any drugs that are approved specifically for remyelination or repairing the injury from MS. So this is really an important question. And there are a few things that are more advanced in clinical trials that are aiming to modulate or sort of upregulate pathways that help your brain recover myelin. So one is clemastine. Another one is an experimental drug called PIPE 307 that are in clinical trials. Not really clear how well those are going to work. I think we're always a little bit cautious just because we've been through a lot of trials, including with biotin and some other things that are also mentioned in the question where we have not seen the drugs really come to fruition. So we're hopeful that there can be a shift in focus just as we have so many drugs that are working to treat the inflammation. Can we hopefully have some more success with actually fixing myelin, but nothing in the immediate future, unfortunately.
Well, I can address some of these questions about symptom management a little bit. I'm going to skip ahead a little bit to our section on this. Just because this kind of relates to a little bit of my talk on fatigue. So there's a question about how do I differentiate between depression and fatigue? And I think this is a super valid question that we ask as clinicians, that there can be a lot of overlap there. And that's why I always ask my patients, and we're talking about fatigue, I always ask about mood and seeing if there's any other symptoms of depression, if it's, exclusively fatigue and it's not these other symptoms of depression like feelings of guilt or hopelessness or, feeling like sad. I mean, that can definitely be a part of depression, but it doesn't have to be there. So I think that if there's other kind of symptoms of depression going on, it's absolutely worth treating the depression, either if that's with therapy or medications or both. And then there's a question about the current drugs for managing fatigue. This was obviously not a part of my talk, but this is definitely something that we still talk about, and we prescribe medications for fatigue sometimes. So there's a few different options out there. There's no specific medication approved for MS fatigue, so we use these other medications in some circumstances. So modafinil is one of them, or Provigil, and this is approved for narcolepsy and like shift work disorder and things like that. And so there is some data behind that, so we'll use that one. We sometimes use things like Adderall or Ritalin, like the ADHD drugs. Sometimes we use amantadine, which is actually used in Parkinson's and was initially a drug used to treat flu symptoms, but we found that it helped with fatigue. And so I would say those are maybe some of the main categories, and there's not great data behind any of them, but there's some, they do help some people, and I think that depending on the situation, it may be worth trying one. It's just, I would always counsel to use medications in addition to some of the lifestyle interventions like exercise and sleep and those things, because those really do make a difference. And I will just mention there are some other drugs that we sometimes use for fatigue, like Ampira or dalfampridine, more for that motor fatigue sometimes. That's like the walking pill for MS. And so there's a thought that maybe that does help a little bit with the nerve conduction. And so again, more with the motor fatigue aspect. And then occasionally we'll use things like Wellbutrin, which is an antidepressant, which kind of has a little bit more of activating effect. But again, all of that is kind of off-label and can kind of depend on if there's other factors going on. Let's see. think there's a question about nutritional supplements that are best for MS patients. This definitely comes up a lot in clinic. And I would say like our main general recommendation is that, vitamin D is something we recommend, and there have been studies showing an association with low vitamin D in development of MS. Vitamin D is also, it's good just overall for our health to have normal vitamin D levels for bones and other things in our body. And that's really the supplement that has the best data. So there's just not a lot of data to support other supplements, which doesn't mean that they may not be worth trying, but I would just always use a little bit of caution with supplements. Some supplements can interact with like blood thinners, for example. So just always kind of like do some digging into these supplements and know that there can be harms from some of them and may not have a ton of benefit. Let's see.
You want me to do?
Do you want to do?
Yeah, so there's a couple group questions about stem cells and stem cell transplant. So I think this is always an important question. So just there's like some distinctions to make. I think, the first one is so stem cells are used really in two very distinct ways. Stem cells are used potentially as a regenerative therapy for neurological injury. So the idea is we can, put in a population of cells that will either go in and replace a damaged area or will go in and like release growth factors and things that help your brain or spinal cord to recover. And so those are the regenerative treatments. Right now, those are not really approved for much of anything, unfortunately. And there's not, really a lot of research that's in late stages to determine if that is effective for MS. Despite that, especially with some current and recent changes to the regulatory environment from the FDA and otherwise, you could probably access getting things like IV stem cells or stem cell injections, not just in the US, but this is a huge component of medical tourism where people travel to other places like Mexico, Costa Rica, Panama, Russia to get stem cell treatments. That has a large number of very concerning features. One, it's often very expensive. Two, we don't know that it works. And three, there's almost no oversight as far as safety. So we've seen a number of really serious complications from patients that do this, which I totally understand the drive because these places will often sell you on a lot of benefits, but that is essentially never been validated in a way like a drug study would be done. So that's one thing. We do hope to have some better options for that in the future, but there's not anything that unfortunately is looking like it's close to coming from the MS standpoint. I think one reason specifically that we are optimistic is for those of you that are familiar with Parkinson's disease. There was some early stage research using stem cells implanted via a surgery into the part of the brain that's injured in Parkinson's that looked like it might be very effective at reducing some of the disease symptoms. And so there's actually a confirmatory clinical trial that is just up and running that we're a part of here at Anschutz to better evaluate that. So I think I'm hopeful that if that looks good, this may provide an impetus for doing some similar studies with MS, probably first with spinal cord injury aspects. I think separately from the regenerative piece is about stem cell transplant, which is a little bit different. So stem cell transplant, as opposed to being a regenerative therapy, is an anti-inflammatory treatment, at least in how we use it. Stem cell transplant was pioneered, of course, to treat blood cancer. So if you have leukemia, you can get really high dose chemotherapy, basically kill all of the immune system, including the blood cells, and then use stem cells that were sort of saved or donated from someone else to regrow the immune system. So that often is super effective in the cancer setting. It's also very effective to treat relapsing MS. And so sometimes for patients that are breaking through on traditional therapies, stem cell transplant will be used for really aggressive relapsing MS. At the moment, we're not really sure though, like, is this a better treatment from an efficacy standpoint compared to the normal drugs like Briumvi or Ocrevus or Tysabri? And so there is a clinical trial that's trying to answer that question called Beat MS that's been running for a few years, as well as some others that are being done in Europe. I think the bigger need though is for progressive MS, and so stem cell transplant has been done in progressive MS in the past. It's not ever, at least with the typical way it's done, clearly demonstrated benefit. We will hopefully have a clinical trial up and running for primary progressive MS towards the beginning of 2026 that will do a new type of stem cell transplant. So stay tuned for that. But I think it's just at the moment, it's not clear that this is a helpful treatment for progressive MS.
I think we're out of time, so.
Okay.
All right. Thank you, guys.